Okay, good afternoon, everyone, and welcome to this special seminar that is co-sponsored by the Department of Nutrition and Exercise Physiology and the Division of Cardiovascular Medicine. So I want to thank Dr. Kumar for his support. And today it's my real pleasure to introduce our speaker, Dr. Naomi Hamburg, who is the Joseph Pita Professor of Medicine. She is the Chief of Vascular Biology Section. She is the director of the Cardiovascular Institute at BU School of Medicine and also an attending physician in cardiovascular medicine at the Boston Medical Center. I want to spend a second to acknowledge her professorship title that is named after Joseph Pita. Joseph Pita, as many of you might know, was a very influential investigator in the field of endothelial function. It was in the early 90s that he established endothelial dysfunction as it develops as a result of cumulative cardiovascular risk factors. In fact, it was in 2002 that he published a very important editorial in Circulation that was titled Endothelial Function as the Barometer of Cardiovascular Health. This paper was very influential to me as a graduate student, as well as to many others. But the reason he was also very influential, Professor Pita, is because he trained the next generation of physician scientists who are now leaders in our field, including Dr. Naomi Hamburg. She obtained her medical degree from Harvard Medical School. She obtained her residency in internal medicine from Massachusetts General Hospital and her fellowships in cardiovascular medicine and vascular medicine from Boston Medical Center. She started her faculty position as an assistant professor at BU School of Medicine in 2007 and moved up through the ranks, becoming full professor in 2021. She is highly recognized for her contributions in the field of vascular function, providing a better understanding of mechanisms that contribute to endothelial dysfunction, but also therapeutics that restore normal vascular function in patients with cardiometabolic disease and patients with PAD, as well as long COVID. Her work has been supported by NIH and multiple foundation grants for the past 18 years. She's an author of more than 200 peer-reviewed publications, many of which are published in very high-impact journals. She is associate editor for Circulation Research. She has served and continues to serve on multiple NIH study sections, and also she's very engaged in her professional organizations, including Society of Vascular Medicine, American College of Cardiology, American Society of Echocardiography, and the American Heart Association. In short, it's a real honor that you accepted our invitation to come visit, and we look forward to her second talk of the day titled Endothelial Health as a Window to the Heart. Endurance. Thank you very much.
Thank you for that very generous introduction, and special thanks to your discussion of Jovita, who was one of my primary mentors, my mentor for many times. And people have asked me today, how do you do all these things and why did you stay? And I attribute that entirely to his support through, I think, that really challenging time as you switch from being a trainee towards thinking about your early faculty career. So honored to have him be spoken about here. So I am going to, let's see. I'm going to start in a similar way to I started this morning, but the story is going to be very different that I'm going to tell this afternoon. So, when I talked this morning about treatments that we have for peripheral vascular disease, this was a cover of a compendium that Nick Leeper, who's at Stanford, and I edited about peripheral vascular diseases a couple of years back now in Circulation Research. And we did this illustration, I think, because of the idea is that, we see patients at this phase or at this phase, and we're thinking about treatments, but we would love to understand what's underlying so that maybe we can get them to go back to this phase, or at least we can prevent them from going forward. And so, and there's all kinds of different science that's necessary to do that. And I've been involved in an array of it, and all you guys are doing amazing work too. So I used to always have the barometer of a slide, but I kind of simplified it into this. So anyway, So, this is a similar case to what I put this morning. And really the idea about understanding endothelial health is that if it's a really integrating component of it's exposed to emerging and established risk factors, diabetes. I'm going to talk about tobacco use. I'm going to at least mention long COVID a little bit today. And they all get integrated. And if we can understand what's happening there, perhaps we could prevent this progression towards actual cardiovascular disease. In terms of the pathobiology of peripheral artery disease, I mentioned this morning that patients who have peripheral artery disease, we know that there's an obstruction to flow, right? That's sort of the characterizing factor. But the degree of the obstruction doesn't necessarily correspond to how they do. You are all thinking about exercise. How do people do when they go on a treadmill? When we put them on the treadmill, their ABI doesn't really correspond to how well they can do. There's all these other factors that are going on. And I think about endothelial function. I hope some of you are thinking about the skeletal muscle and what's happening there, and inflammation and oxidative stress. And so, when we think about exercise training, which we know makes people with PED better, we think it's probably not decreasing that plaque. Maybe it is, probably not, but it's maybe affecting many of these other things that allow them to walk further. So how do we understand what's happening with vascular function? And so, when I started thinking about endothelial function, which I did as a medical student working at the Brigham with Mark Krieger, Peter Gans, and Marie Gerhardt, and we were actually working on hormone treatments and endothelial health. This is prior to the Women's Health Initiative. We use, as we still do, a lot of methodologies to look non-invasively at what's going on in the blood vessels. And I know you do too, but we still looking at flow-mediated vasodilation, which is a way of using increased shear, the property that increased shear stress is a stimulus for nitric oxide production. We can look at blood pressure and pulse wave analysis. I've done a lot with looking in the fingertip using peripheral arterial tonometry as a way to look at small vessel function. Actually, the reactive hyperemia that we get during the measurement of the flow-mediated dilation is also a nice partially nitric oxide dependent measure of nitric oxide of vasodilator function in the small vessels, and then a number of ways of looking at stiffness. We have done many of these techniques in the Framingham Heart Study. So when I was talking with your graduate students, we've done PAT in close to 3,000 people on both the offspring and the third generation, and flow-mediated dilation again was even more. And the stiffness we've measured in multiple generations 3 times. So there's longitudinal data about stiffness, and it is a data set that, if people are interested in collaboration, they should always reach out to us if you have some new idea about what to do. In PAD in our laboratory, we showed that, having PAD and even worse, the combination of CAD and PAD is associated with lower flow-mediated dilation. And in Framingham, looking at FMD, it was actually the reactive hyperemia that was most predictive of events, and in part mediated by stiffness. And sort of the idea there is that as you get more central stiffness, you have microvascular damage, and that may be leading to events as a mediator. Looking at the PET response, it was actually most predictive of stroke. This was Leroy Cooper, who's faculty at Vassar now. Seward County was a fellow with us, and he's at UMass faculty. So that was actually interestingly most related to predicting stroke risk. So there is some association of these measures of vascular function with future events, but we then try to complement what happens at the cellular level. So we started doing this, some of you are too, this endothelial technique, biopsy technique, around 2007. We've largely done venous endothelial cells, so most of which I'm going to show you today is from venous endothelial cells. So the idea is that you place an IV and then use a J wire that has some contact with the endothelial surface, and you get some endothelial cells directly from the patient. And you can either look at these using quantitative immunofluorescence or using techniques to do RNA sequencing. So, for many years, we struggled with separating them. Now we do just a single bead magnetic separation to enrich for the endothelial cells. As all of you who know do, that's not going to get you pure endothelial cells, but when we look under the microscope, relatively pure. We tried a lot of other methods like complex flow cytometry, but the problem is that these endothelial cells, I think partly because they just got scraped off, they're not very happy when they go through flow cytometry, and then the RNA quality was really poor. You get a few thousand cells. So the first study that I was involved with was, as you all know, we think about insulin signaling as being important in terms of glucose metabolism, but there's also insulin receptors on endothelial cells. And there had been many animal studies that had shown, and physiologic studies showing vascular insulin resistance in the setting of diabetes, but we wanted to see what was happening at the endothelial cell level. So we took the cells, so these are all on the freshly collected cells, and we're able to show that when you stimulate them with insulin, in the healthy control people, you see an increase in nitric oxide with DAF2-TA, and you see an increase in eNOS phosphorylation at a positive regulatory site. It's interesting that what we see largely in diabetics is actually that this goes down. It's that there's actually a little bit higher basal phosphorylation, and then you actually see it go down with insulin. And there's some association between the response in these endothelial cells with flow-mediated dilation. And so we've gone on to really say, okay, what can we understand about why this might be happening? And a lot of people ask me, so are we culturing the cells? What are we doing with the cells? We can keep the cells for some time, but this was work that we did looking at sort of glucose modifications and what happens. So if you keep I'll talk about the glucose story, but if you keep the endothelial cells in normal glucose just for 24 hours from people with diabetes, they actually respond fine to insulin. So I really do think the strength of these cells is that they just came out of whatever the milieu was of the patient. If you put them in high glucose, they still have abnormal response. And then he looked at Oglick-Knack modifications on these endothelial cells, which were higher in the people with diabetes and associated, not surprisingly, with their degree of glucose control, either measured by fasting glucose or hemoglobin A1C, and then use some modulators to try to see what happens if you prevent this restoration with normal glucose, and could see that prevented the improvement in response to insulin. And so, there are many different targets that are probably modified. This modification is kind of similar to phosphorylation, and that's a dynamic modification. And so, what are the targets that may be in the endothelial cells? But I think one piece showing that, at least in some part, glucose is responsible for this. And then I think the positive message to me about this is that, while we think about a lot of things being not reversible with diabetes, clearly this looks like this is reversible. So to me, that's encouraging. Obviously there's parts that don't get better in the vasculature, but I do think that there's a lot of hope that this is a dynamic state. And so we've done a number of different papers trying to look at different ways, and I've summarized a number of them here. We're interested in this idea of organelle stress, and obviously both of these are complicated processes with mitochondrial dynamics and stress and ER stress, but I'm just going to show you a couple of pieces of data here. So we showed that there's more fragmentation in the mitochondria in the endothelial cells for people with diabetes. There's a higher production. This is using mitosox as a marker of mitochondrial ROS that's higher in these endothelial cells. And then in terms of quality control, so looking at autophagy, so P62, which is a marker that turns over with autophagy, so clearing out of abnormal organelles is higher in diabetes. And we could, again, take these cells and treat them. This was longer with spermidine, which is actually a nutraceutical found in a number of different foods that we could improve insulin signaling. That's thought to improve autophagy. And then we did some ex vivo studies with GLP-1. We both improved their insulin signaling with treating with GLP-1 and reduced ER stress with a number of markers. I'm showing you here phospho-IRE1 alpha. So as we've been talking about, there's some controversy about whether there's GLP receptors on endothelial cells, but it seemed to be in our work, at least in these cells, receptor mediated. So it's not probably as high as others, but I think we still need to understand better what's happening at the vascular level with these agents. There's some connection between ER stress and mitochondrial stress. So this is unpublished work where we looked at TUDCA, which is also a nutraceutical for ER stress, and could reduce the not every thing came up, but reduce the ER stress and lower J&K, a marker of inflammation, and that it can improve insulin resistance in the cells from people with type 2 diabetes and actually restore the mitochondrial morphology and improve their reduce their mitochondrial loss. I think more work to try to figure out in which direction that's going, but I think there's clearly interplay between these two forms of metabolic stress in the cells from people with diabetes. And then trying to look at RNA sequencing. So again, we get small amounts of RNA. So this is sort of in an early data set that have now expanded. But when we look at least pathways, a lot of pathways, again, related to mitochondria and ER stress seem to be activated in the endothelial cells from people with diabetes. And then looking at so then we have been working a lot on microRNA as well. Again, these are microRNA, so non-small non-coding RNA from people with and without diabetes. And there were a number of both up and down regulated microRNAs in these endothelial cells. And the postdoc, St. Rizvi, who's working on this, really focused on microRNA 409 3P because it was one of the more highly differentially expressed in our sort of early pilot, and then again replicated in our larger set, as well as there's some data that it's related to vascular biology. So I keep changing only one side. Okay. And so he went on to show, not only is it higher in the cells from people with diabetes, he did then some cell culture work to try to look at how it may be important in terms of signaling in these cells. So this piece here is from cultured endothelial cells. When he puts them in high glucose, he sees this impaired insulin response, similar to what we see in the patients. And this can be improved with inhibition of microRNA 409 3P. And then one downstream importance was, again, phospho-J&K, which we'd previously shown is higher in the endothelial cells from people with diabetes in prior work. And so it looked like part of this was mediated through J&K. And then these are now from the cells, from the patient cells. He actually managed to do a microRNA inhibition in these cells, which was a real feat. It's interesting when I have people come from people who are experienced in cell culture, and then they want to do often they're planning very ambitious sets of experiments with these endothelial cells, and I always say it's going to be a lot more technically challenging than you think, which it was. But he did manage to achieve this in these cells. We've also done some work with O-link biomarkers showing that there's some association between at least in a small number of people, the level of microRNA 409 3P with markers of oxidative stress in terms of circulating markers. So I think really trying to, in all of that diabetes work, really the idea is that can we use multiple different ways to see what's going on in the endothelial cell, and combining different types of approaches with using RNA biomarkers. We still can't do full proteomics, right, in our endothelial cells. We're not getting enough, but selected markers. I wanted to show you, I know a lot of you do adipose biology. I'm not an adipose biology person, but some of the people, I don't know if you know Noyan Goki in my group, who does a lot with looking at adipose tissue from people undergoing bariatric surgery. So, and was looking at angiogenesis. So we had this idea to be able to take the fat tissue from people with PAD who are undergoing bypass surgery, because one of the challenges is that we don't really have great ways to look at angiogenesis response in people overall. And so we took subcutaneous adipose tissue, both more proximal and more distal. So the distal is presumably more ischemic. And as controls, we used people who are undergoing knee replacement who didn't have PAD. And we looked at angiogenesis and then looked at microRNA. And so this just came out. So interestingly, there wasn't a significant difference in our small number of people in terms of the degree of angiogenic response in the proximal, but there was a marked difference in the distal, so the more ischemic. We see impairment. So this is again, so we take the fats and matrigel assay looking at angiogenesis sprouting over 7 days. And then there were a number of microRNAs that are linked to important pathways in angiogenesis that were also altered in these fat samples. So, people, I think it would be nice to be able to do this in muscle too. But I think it's interesting that the fat is maybe not a bystander tissue here, which people haven't looked much at all in the fat. People are always focusing on what's happening in the muscle because presumably that's what's causing symptoms. But it's also ischemic. So you wonder if it's also contributing to the metabolic differences. I wanted to just put one of the other pieces we've done recently with the endothelial cells in collaboration and linking it to PED. So, I said I started actually being interested in sex differences and hormone replacement therapy. I've come along from that. I know some of you are working on these things, but we know that interestingly, women get PAD probably at later ages, right? But there's still a substantial burden of PAD in women, and a lot of this is from traditional risk factors. But I think we've under-recognized some female-specific risk factors, both for clearly for things like heart failure, but also for atherosclerotic disease. And so we've been starting to try to look at preeclampsia. Actually, we just, along with Emily Lau, who's at MGH, she just got her first R1. She's had her K looking at women through the menopause transition, and we've been collecting endothelial cells. I don't have any data from that yet, but she just got her first R1 to look at women with high rates of hot flashes and then use the new neurologic drugs for treating hot flashes and looking at multiple markers of vascular function, including collecting endothelial cells. So that's just getting started. But this was a study I did with Mike Honenberg, who's also at MGH, looking at women just after preeclampsia. So taking women with preeclampsia and normotensive. And there were a number of different things, but we included doing this endothelial isolation. And one of the, in the RNA sequencing, METAP1 was more highly expressed in the women who had preeclampsia. And he did Mendelian randomization looking at arterial tissues, actually linking vascular METAP1 expression to preeclampsia. So some validation in terms of genetic models that this may be important. And then some cell culture work that showed that actually the METAP1 overexpression in HUVEX it was associated with decreased angiogenesis as well as increased inflammation, and that could in the opposite direction with knockdown. So we're really interested and hopeful to continue this work to understand what's happening in preeclampsia and really follow. This was a relatively small set of women. I'm going to spend the rest of the time talking about another area that I've been doing a lot with tobacco products. This was from review with PAD. So, we know that, it's interesting. And I said this morning, it's kind of goes without saying, right, that smoking causes heart disease. We all know that. But the really interesting thing is that, which sounds boring, we don't really know exactly what it is in even traditional combustible smoke that causes heart disease and heart attacks. They know the cancer people, they pretty much know that it's the tar, right? And so that causes cancer, but it's not been clear exactly what component causes athero or causes thrombosis. And so then when we have these novel tobacco products like e-cigarettes, the cancer people say, well, there's a 95% less risk in these products, but they're really talking about the fact that there's not tar there. And so it's hard to extrapolate that entirely to the vasculature because there are a lot of there's certainly VOCs, volatile organic compounds, and other metals and other things, and obviously nicotine. We don't really think the nicotine is probably the most causative for atheroma, although it may not be as benign as we think, nicotine being that. So again, clearly there's a lot of things that tobacco does to the vasculature, and the hazard ratios are very high. We don't have a lot of we just really have minimal data about e-cigarettes in terms of predicting risk, and also the epidemiology, the demographics of people using e-cigarettes have changed a lot from the early being mostly people who were former smokers. I'll show you that from some of our data, to now a large number of people who had never used combustible cigarettes. In terms of quitting smoking, this is data from Framingham that you do get benefit from quitting, whether or not you were a heavy smoker or less heavy smoker, and that happens pretty quickly, though it continues to give you benefit over time, but you get a lot of the benefit early on in terms of the, so I think, again, for cancer and some other things, smoking gives you this cumulative risk that you've already experienced. Not that it's not important to quit, but you can go back towards that of being non-smokers from quitting in terms of your heart disease risk. And we looked, this is just a graphic from we looked in the Framingham, what about arterial stiffness? So we had, again, longitudinal arterial stiffness, and we looked at just what happens after quitting smoking. And not surprisingly, active and past smoking was associated with increased stiffness, at least measured by augmentation index, and as well as central pulse pressure. But if you stop, their time since quit was definitely associated with improvements in this. You don't get back to where you would have been if you never smoked, but it definitely improves over time. And those who, when we then did a longitudinal, like looking at people over 2 exams, those people who persisted in terms of smoking had the greatest increase in their augmentation index between time. So when I think about e-cigarettes, and I alluded this a little bit, like one of the really interesting things about working in this space was thinking about regulatory science. I don't know if any of you think a lot about regulatory science. I didn't think about regulatory science at all before thinking about, we thought about mechanisms. So a lot of the funding for this tobacco-related work comes from actually the taxes on cigarettes. From the 2009 Family Tobacco Control Act. There was taxes, and part of that was supposed to go into research to improve regulatory science about tobacco. So it's actually a joint FDA, NIH funding. And so you're not supposed to look at mechanism. You're supposed to look at a number of other things, but actually the law specifically said it can't be about mechanism and it can't be about cessation. So the idea is that you're kind of looking for biomarkers of harm and biomarkers of harm reduction. And so, yeah, it was a sort of a whole different way of training people and thinking about it. But I think it's really interesting because it's like a very different way that your science can have an impact, right? Your science can have an impact on thinking about regulation, and regulation is probably the most effective way to reduce smoking overall. But in terms of e-cigarettes, their mandate overall, if what the FDA mandate is when they think about whether or not to approve for sale new tobacco products, because they have the ability to regulate electronic cigarettes, they have to ask what the net public health impact is. That's their metric. And so what they think about a lot is this, which is what are you getting from the smoking state towards the non-smoking state? And if that's the case, that probably has a public health benefit. This is going to be probably a public health harm, right? You're taking kids who weren't smoking. I say kids because most people pick up these products when they're young. And then they're taking up e-cigarettes and potentially transitioning to other products, including combustible products. And so that's really how they've decided about all the products that they currently have allowed for sale. But we've been really interested in when you're in this electronic cigarette state, what's the risk there? And is it less harmful or not? So we had two large cohorts, and the first one, this is all collaboration with the University of Louisville. So it was a mixed cohort recruited at the two places. And actually, initially, it was designed to be about combustible cigarettes when we started, I think, in 2014. And then we added the e-cigarette piece. So these people in our first cohort, they came in the morning not having used their product. We did different measures of vascular health. You can see here. We divided them here into dual users, so people who use both products. These are just combustible users. These are exclusive e-cigarette users, but everyone in this initial cohort was a former smoker. And that was largely who was using them at the time. And interestingly, their flow media dilation was not different in their sort of fastest state. And what was different was the AI, which seems to be the augmentation index, which seems to be one of the most sensitive markers to smoking compared to these others. Many people, and I'll show you some have looked at the acute effects. And so this is a meta-analysis that came out. This is sort of the earliest paper that came out in 2016, looking at both traditional and e-cigarettes. These are all in users, had an acute impairment in flow media dilation. And that seems to hold up in terms of heart rate and blood pressure. You see an increase in heart rate and blood pressure, both systolic and diastolic blood pressure with acute use. And what about stopping? So this was one study that they actually took people and they continued on their cigarettes or gave them e-cigarettes with or without nicotine, and both saw an improvement in FMD. Again, these are people in combustible users, so suggesting perhaps a healthier state. But what about this dual versus sole? Again, and I showed some of this data this morning. This was a lot of work from Andrew Stokes, who's done a lot. He's at our School of Public Health and looked at the PATH data, which is a nationally representative, overrepresented for tobacco users study. And in the people who are exclusive e-cigarette users, while they have higher markers of inflammation compared to non-use, it's lower compared to smoking if they're exclusively using e-cigarettes, but not in the orange if they're dual using. And that is the as you saw probably in the slide before, it's more common to be, if people who are former smokers, much more common to be dual using. So they really need to get at least to that exclusive e-cigarette, which I'm not sure is happening in that many people. We saw this similarly in the past study. We looked at chest pain, which they collected at one exam in people who are over 40, and sort of a similar pattern. that relative to non-use, exclusive e-cigarette use seemed to be similar in terms of the amount of chest pain that they reported, but the dual users had more chest pain relative to non-users, and all of these were fairly similar. So low trending towards lower with exclusive e-cigarettes. So maybe this message that if you could at least get to exclusive e-cigarette that from cigarette use, that could be beneficial. And then, but what about the other side, about young people who are using, and e-cigarettes by far and away are the most commonly used in high school students, up to 14%. And this is true across, for most of the people using, so here's the e-cigarettes. This is any product. This is e-cigarettes, much more common than any of the other tobacco products. And in high school across all the racial groups, there are some racial differences. So we had this large AHA grant as well to try to, that was a multi-component project that looked at both some of these vascular health effects, and then Joe Wu was doing IPS work with the components, and then psychologist who does cessation developed this virtual reality cessation program that she trialed in high schools. But I'll show you some of our endothelial cell work. When we look at e-cigarette users, so these now this is what happens with acute use. So we do have a space in our laboratory that has high airflow so people can use products. We did in the beginning, like we had to go outside, but there's all kinds of things about going outside in the winter, right? So they're all controlled in the laboratory, can smoke or use e-cigarettes. So in terms of the change in FMD, you can see that pretty similar across the people who are sole, dual pod users, combustible cigarette users, and non-users. This is, again, they come in to the laboratory, they use their own product, they bring their product, and they use them in a standardized fashion. And then we collect the information before and after the use, and these are the change metrics. So again, acute impairment across all the different. This was from work then a couple of pieces from looking at the endothelial cells in terms of looking at the nitric oxide production. It looked like there was a similar impairment in nitric oxide production now with 823-187 as a stimulant. The production was impaired in both groups. And then looking at eNOS phosphorylation, the change in eNOS phosphorylation here with insulin, you see that it's impaired across both the cigarette smokers and both the dual and sole pod users compared to the non-users, although there's a lot of spread there. So it's kind of interesting to know. We do have a lot of heterogeneity in product. So is there some specific element? And I'll show you a little bit about, so Sarah, yeah.
MD, how many minutes was that? Do you remember?
We do it at 30 minutes after.
30 minutes and you get huge dose. Wow.
Yeah. And we were just chatting about this question about how much do acute effects matter, right? But I didn't put some of this data in here, but when we ask these young people, so these are young people, they're 18 to 40, but most of them, the average age is 20. So most of them are college students. And they had to be regular users. So they had to use at least 3 days a week for at least 6 months to be enrolled in the study. And when you ask about their use patterns, they use on average 28 out of 30 days, and they use more than 15 times a day. So, which is the better measure, the fasted measure or the post-use measure? Because they're really staying in the post-use state for most of the time. These are all, so it's pod-based. So the earlier generation e-cigarettes had a different nicotine formulation, and then with everything from sort of Juul on has a nicotine salt. And it's much more the nicotine delivery is much higher and much more similar to smoking. Yeah.
Anesthetization of the cilia and the lungs like smoking cigarettes does. Do you have a smoker's cough when you vape?
I don't think, I've not heard people say that, although they do really like the menthol. I have a little bit about flavorings, right? So it probably still must be causing some irritation because by far and away people choose something that has a menthol and then but it has high nicotine delivery, so probably some of this is definitely related to nicotine, and they're all clearly addicted by using at that rate. They're not, a lot of the early studies, earlier descriptions where youth use were just kind of using occasionally, just trying to use, but not this chronic use. We've started to try to do some of the RNA sequencing. So most of the pathways that were elevated in both groups here were inflammatory pathways. So very different from diabetes, but not, sort of similar probably to other studies. So in terms of what happens with cigarette smoke to the endothelium. And then I was going to show about flavorings because I think so. Most young people use a flavored product, right? 8 out of 10 use a flavored product, and all different kinds of flavors. So these, so in combustible cigarettes, right? You can't have any characterizing flavors other than menthol. That's the only allowed characterizing flavor in combustible cigarettes. E-cigarettes don't have those rules, and actually little cigars, which are really similar to cigarettes, can have all these different flavors as well. The only difference is they have to have a higher percentage of tobacco leaf in the wrapper. A traditional cigarette has only paper in the wrapper. So we did this study looking at flavors, and so all of these flavor compounds, are approved as GRAS, right? They're all generally regarded as safe for food. And so we were, tasked to try to figure out, so the supplement we had to try to figure out, what was their vascular effects. And, it's interesting, there's no great standard toxicology for endothelial cells. And so we kind of came up with some different ways, but, I think sort of in, people tend to look in myocardial cells about EP, about conduction and things like this. But anyway, so we looked at a number of things, including inflammatory markers and nitric oxide. But somewhat to our surprise, pretty much all of the flavors reduced nitric oxide. Even tended to be at higher concentrations, but had some effect. So I've sort of thought about this in terms of our now government's interest in ultra processed foods and flavorings and things like we don't really know. Probably if you eat them, right, they're going to turn into something really different. We did some with heated. This was just showing you the actual chemical put on cultured endothelial cells, but we did have collaborators who did a whole heating process, and you see similar things. We don't really know what the concentration of any of these things end up in blood after people smoke or vape. Or eat things, I think, for the matter. People really haven't tried to look at these in circulation. In terms of looking at our patient endothelial cells. So when we took from cigarette smokers, whether you use menthol or non-mentholated cigarettes, their nitric oxide was impaired for both. So, and that's pretty consistent with the literature in terms of the epidemiology. The risk of, say, heart disease is pretty similar when you add menthol to combustible cigarettes, because you're getting so much impairment from just the combustible cigarettes. You don't see much more, I think, just from the menthol. But when you add it, when we took endothelial cells from healthy people and just treated them with menthol, they were impaired. And also with eugenol, but this, which is sort of this clove flavor, right? Which, so some acute impairment with these products. So in Massachusetts, we are the first state to have a flavor ban on all combustible all cigarette products. So this is our former Republican governor, Charlie Baker, signed into law. So June 2020, and we were still recruiting across that time. California is the only other state, but we have so Massachusetts, California. So we started to see people reporting using these products that were labeled as clear. They look like this. They're common, typically like these white boxes. This is like one of the pod-based things that have emerged. So we looked at our data of these people, again, when people come in and use their own products, of the clear e-cigarette users and what happens. And I'm just looking at the blood pressure and heart rate changes. And actually the increase in heart rate and blood pressure was higher with these clear products. I think we need more to understand this, like what is it that's making it more dramatic. And we collaborated, I didn't put it in here, but we collaborated with a group at Yale who bought a whole bunch of different clear e-liquids, and they do full characterization. So they all have these synthetic cooling agents in them, and many of them had other flavorings in them as well. But pretty much all of them had these synthetic cooling agents that have been around forever. The tobacco companies have had them forever, but they haven't used them because they've all been able to use menthol, but in the absence of being able to use menthol. And so the users, they don't switch to using tobacco flavor, really low rate. They either go to other states to get flavored ones, so a lot of still use of flavored, or they are using these that still have that cooling sensation. Just a couple other things I have going on. I've been working a lot clinically. I'm seeing a lot of my practice. I do the cardiovascular long COVID. I think it's fascinating, and you guys all do exercise physiology. So I'll just tell you that what these people have. So I pretty much always do a metabolic stress test on all of them, and some of them I do metabolic stress testing with a catheter. And they have profound exercise intolerance. You have these like 20-year-old people like this. They have this autonomic dysfunction, so they have their heart rate. People call it POTS, but if you do tilt table, they're mostly not. They don't test positive, but they just have like intermittent, their heart rate goes up to 150 and they feel terrible. Can be with minimal activity, can be at rest. But anyway, on the metabolic test, they reach their, some of these people have VO2s of like 3, 4. That's terrible, right? They're terrible. And when you have the catheter in, their cardiac output is fine, their respiratory is fine. They just don't extract oxygen. And so I know you're all. I think it's a huge problem that we need to figure out, like what is happening in these people, and how are we going to be able to make it better? Because a lot of them don't get better. And the evidence from the long I'm involved in the NIH long recover trial, this is the one. The more severe people have their symptoms, the less likely they are to go away over time. So we along with Jen Ho at the BI have this R1 that we really started as the idea was that we would, the observation that people with obesity did worse with acute COVID and what happened to them over time, like with what happened to their vasculature over time. So we're doing, the endothelial cells, FMD, and then we're also doing coronary microvascular function with PET. That's on Marcelo DeCarli at the Brigham does that. And it really then kind of morphed into a long COVID study because that was really the people we were seeing. So it's a little bit of a combination of, over time we did at baseline and at 6 months. So I don't have any data from that, but we're all in the data processing phase. And then I've mentioned to some of you this endothelial health in the Framingham heart study. So we collected, so in the Framingham 3rd generation and Omni, which is the whole exam was over 3,000. We did it as a callback. And so I think completion. We did, I think, 1,100 collections in the Framingham Heart Study, which was a total like ramping up of what we're used to doing. You're probably all used to, again, to, we were sort of like a participant or two a day, right? So being able to do ramp up to do 5 or 6 a day, both for collection and processing. So now we're have the RNA and all the slides. So now we're working on being able to increase our throughput for all the microscopy. So I think we've done it. Like we've gotten some things. I don't know if you're doing this. We sort of work to have like an automated, being able to take the pictures in an automated way for the immunofluorescence. And then I don't know, they say that maybe we can AI image. I'm not sure about that. I think people just like to say that AI will be able to do it, but maybe it will. But at least like they can capture the cells for the analysis. And I talked this morning about, thinking about the patients with PAD. We have a lot of sort of standard therapies available for them, but I think all of this suggests that maybe there's a lot of other things possible that we have that hopefully can either improve their functional status or maybe reverse their athero. With that, I should just thank, this is some of the many, many people. I tried to put on some of them, the trainees who are involved in the projects. Many other people have been involved in many of these and some of our collaborative projects. We have a place in Stowe. We came and made a snowman. That's our place. And for some of them, they've never seen snow before. So it's kind of interesting. We don't get enough snow in Boston. So with that, thank you all for your attention and meeting with me today, and I'm happy to take questions.
Yeah, really cool talk. Very, very topical now. I was curious on like your, I don't know how to put it, but like record keeping when like, you have a participant coming in, they like break their own vape. Are you like keeping, because especially with like ever since the FDA cut out like a whole lot of whackable companies like producing and distributing these, how are you, I guess, like trying to categorize them based on like composition and like just general quality as far as like what's actually in that thing that they're smoking and throwing away a week later?
Yeah, it's interesting. So we do we take photos of what they bring in. We have not had people. So I mean, there's a lot of nuances to different things. It was interesting so in the first iteration, we didn't do acute use, but people like reported using all kinds of different things. Then there was a period of time when we first started this acute use that I would say like 95% of people were using Juul. I was like, oh, it's going to be more consistent in this study. And then no one was using Juul, right? So because the story with that, right? So Juul really was the first product that use nicotine salts. It's the way it works. You have the stem and you throw away the component that holds the e-liquids, and the FDA was concerned that they were increasing youth use and advertising to youth, and they were really cracking down on them. And so they did away with everything except for tobacco and menthol flavored. But then the way that the FDA put out the regulation, they said it was only for these ones with the disposable pods. And then but if the whole thing was disposable, it didn't count, right? So then you had all these ones that the whole thing is disposable. And when they first started out, it was like these puff bar ones that had basically as much liquid as the Juul in one. So kind of like a day's worth for people. But now, like the ones that they have, like some of the clear I showed, but they'll have like 2,000 puffs or something. So they're disposable over like a really long period of time. So that was a long way of answering your question that we really didn't have people that came in this study that were like filling their own or like putting other stuff in there. We didn't see a lot of that. Even after like the flavor ban in Massachusetts. I mean, we're a relatively small state with a lot of states around us, and students go other places. So, most of the people were still using a flavored product. Also, I think the stores still sell them, even though, right? Because there's not a lot of enforcement. So they'd be like, oh, don't you want what's behind the counter? So yeah, so good question, but I don't think we had a lot of that. That doesn't mean that there's not a lot of different stuff in there. So, even when the Yale group characterized all these Cleary liquids, they're very variable in terms of a lot of different things. So we really do need to understand better, I think, the individual components. It's just a huge undertaking to do that. Yeah.
Thank you so much for your talk. I'm really interested in the e-cigarette portion also, but more so in comparison to cannabinoids.
Okay. Yeah.
Because I know that cannabinoids have a lot more regulation around them just because of the legality of it all. So what I'm curious is more of a speculation. Do you think that people that are maybe habitual users of these cannabinoid vapes versus nicotine vapes are having similar function? There are more regulations around it. Perhaps there's less ingredient, nicotine, probably not in it. Any thoughts on that?
We have not done any like acute cannabis studies. It's a whole process to be able to do that in a place of education. Even people bring their own. I mean, you can do it. It's just a big process. We do need to go back and look at some of these people are using cannabis for sure, right? They're all called in state where cannabis is legal. And so I haven't, it's on my agenda. And I think that one of my undergrads is supposed to be organizing our data to look at that question. I mean, that's just going to be cross-sectional, were the changes different amongst people who reported. But the group at UCSF has done some acute use studies, both with edibles and with smoking. And interestingly, they saw impairments in FMD both with edibles and with smoking. They didn't do the combination. I haven't seen anything yet about the combination, with a nicotine product, which people often do, right? Even mix the two together in the vape. I have not seen anyone do that yet, because I think really the UCSF group is kind of the one that has the ability to do the acute use in California. I sat, still do, on the advisory for California also has a tobacco research program. So they have a high tobacco tax. So they have about $80 million a year that goes to science and tobacco, and they also are interested in cannabis, but there weren't a lot of ever proposals, both when I reviewed and then I sit on the science advisory committee about cannabis, probably because it's harder to study. Yeah.
The results that you show on FMD after their acute exposure to smoking, you presented data on phenol phosphorylation and on DAP measured nitric oxide, and all that points towards reduction in nitric oxide production. Do you have any other data that may suggest that, for example, production of reactive oxygen species are just scavenging the nitric oxide? I don't know what is the ratio of fluorescence decrease in DAP in the presence of reactive oxygen species who win, whether DAP or reactive oxygen or ROS to peroxide to capture the nitric oxide. But do you have any other data to see what is the main
driver
culprit of FMD reduction? Is it mostly just a reduction in NO production by phenol phosphorylation, or is it something else that is scavenging nitric oxide?
I mean, we did show in the cells that the mitosox was higher. We never did trying to do combinations to see what component of the decrease in NO was we didn't use an antioxidant and then look at NO. There's just to some degree a limitation. I don't know. I'm trying to think about some of the other cell culture work that other groups have done, if they've answered that question well. Because again, the group at UCSF that we collaborated with has also done some of this work and done there's animal models looking at these questions as well. A lot of it is, and I didn't show this either, like if in people who've also looked at like with and without nicotine, a lot of the acute decrease in FMD is nicotine mediated. So at least in these young, healthy people. So, is that like related to the nicotine receptors or something else? I think that work still needs to be done.
Folks, so please join me in thanking Dr. Hamilton.